السلام عليكم يا جماعة. إن شاء الله النهاردة هنتكلم على موضوع مهم هنختم بيه الليكتشرز على المودزلي جايد لاينز of the use of different psychotropic drugs and medications in special populations. Today we'll talk about psychotropic drug choice in pregnancy. First of all, a very important thing about the normal outcome of pregnancy can never be guaranteed. Why? Because there is a percentage of spontaneous abortion, about 10 to 20% of all pregnancies, risk of spontaneous major malformations without any effect of the mental illness, any effect of our drugs, 2 to 3%, or 1 in 40 pregnancies. يعني 1 pregnancy every 40 pregnancies وارد ان يبقى فيهم spontaneous major malformations. النقطة الثالثة ان اللايف ستايل فاكتورز influencing البريجننسي outcome. يعني حتى اللي بيحصل البريجننت women او women بيعملوه during pregnancy will affect the fetus or may affect the fetus, like smoking, poor diet, drinking alcohol, even moderate maternal caffeine consumption may be associated with low birth weight. Pre-pregnancy obesity, which is a very important factor, especially in those patients who used to receive olanzapine, for example. Most of them will have increased body weight, or even without the use of any drug, if the patient from the start is already obese. The pre-pregnancy obesity increase the risk of neural tube defects, وبالتالي زي ما احنا عارفين كبروفيلاكسس ان احنا نحاول نقلل الريسك ده دايما بنريكواير higher doses of folate in these obese pregnant women، سواء عندهم mental illness، سواء بياخدوا psychotropic or psychopharmacological drugs, or even obesity without any mental illness or without receiving any of our drugs. The most important point is that psychiatric illness itself during pregnancy is an independent risk factor regardless of medications. The illness itself is a risk factor for congenital malformation and perinatal mortality. So the effect of illness sometimes is more serious and more harmful to the fetus and even to the mother more than the use of our medications. So what about drugs? We talk about the lifestyle, we talk about spontaneous abortion, about spontaneous major malformations. What about drugs? The percentage of the harm for the fetus by our drugs. It only accounts for 5% of the total abnormalities in the fetus. Major malformations in the first trimester, because all of us know that this is the first 3 months is the period for development of the fetus, okay, and formation of the fetus. So if we use our drugs in this period, there is only 5% risk of major malformations. At the end of pregnancy, the third trimester, the problem is that the neonate after delivery, the neonate in the first months of life may have neonatal toxicity secondary to medication used by the mother. Longer term behavioral and increased risk of minor health problems in adult life. So the drugs, which only account for 5% of the problem, may present in the form of 3 different harm. First of all, if the mother receive our medication in the first trimester and these medication are better avoided during pregnancy, so they may have major malformation. If they receive those drugs in the last trimester, so this may lead to neonatal toxicity, and after birth and later on during life, longer term behavioral and increased risk of minor health problem in adult life. To assess safety of psychotropics in pregnancy cannot be clearly established, as robust prospective trials are obviously unethical. This is a very important point, because simply We cannot do a lot of research using pregnant women, and we try to found an evidence-based about trials of many of our drugs just to have a percentage or an evidence-based results. It is of course unethical. That's why it depends on past experience. For example, if we use an old drug for more than 1 decade and no harm detected, so this drug could be used during pregnancy. But we can't do research using drugs on real pregnant women. Okay, before we talk about our drugs, this slide is very important. Any pregnant women that can come to you at outpatient clinic, what to include in discussions with pregnant women? What are the points that you have to focus and discuss clearly with any pregnant women that come to you to follow up with you? There is 7 points. Number 1, ability to cope with untreated illness. If she can cope with the illness without use of any drugs, we can stop the drugs and we can use any measures aside from drugs, so it will be perfect, because we now avoid the risk of that could be done by any of our drugs. Number 2, the potential impact of untreated illness on the fetus. She has to know that the illness itself, as we mentioned before, has a potential risk on the fetus, not our drugs. You must say it clearly or focus on this point. Number 3, the risk from stopping medications abruptly. This is a very important point, that most of the pregnant women, once they know that they are pregnant, they start to stop the drug by themselves immediately without and abruptly without consulting the psychiatrist. Severity of previous episodes, response to treatment, and woman's preference. This is very important. And by the way, from the start, if you read Maudsley guidelines from in the first 2 pages, you find that the preferral of you have to let the patient or the client choose what he or she prefer regarding their treatment and management. Number 5, that you have to focus and include in discussion in every pregnant woman that could come to you in your clinic, the risk of malformations for pregnant women without a mental disorder. As we mentioned in the first slide, there is 5% risk of spontaneous malformation. Number 2, there is a risk of the illness itself. Number 3, risk of our drugs. The increased risk of harm associated with drug treatments during pregnancy. This is very important, that you let the female or the pregnant women to know the risk of the drug that you prescribe to her. Number 7, the possibility that stopping a teratogenic drug risk after pregnancy is confirmed, of course, may not remove the risk of malformation. It's very important. If there is, if your patient is planning for pregnancy in the future, of course you have to tell her, once you detect that you are discovered that you are pregnant, okay, stop the drug immediately. But in spite of stopping the drug, because sometimes they discover that they are pregnant in the 2nd month, sometimes in the 3rd month, and she received the medication all through this period. You must clarify this point to this female, that it could be some teratogenic effect from these drugs. Could happen, especially in the drugs that better be avoided during pregnancy. Individualized written material should be provided. This is very important. Must be written material, okay? Like a contract or something, to know that these are the risks and you know about it, and I told you already about it. Absolute and relative risks should be described using natural frequencies rather than percentage. For example, it is better for our patients, pregnant women, to tell her that the possibility of the risk from the illness, from the drug, whatever, is 1 in 10. This is better then you told her it is in the way of percentage, like 10%. So it is better to tell her 1 in every 10 pregnancies, there may be a risk. And common denominators, for example, 1 in 100 and 25 in 100, to compare between, for example, 2 drugs. The risk of this drug is 1 in every 100 pregnancies. The other drug is 25 per 100 pregnancies. It's very important. And rather than, of course, 1 in 100 and 1 in 4, it will confuse the patient, of course. First of all, we'll talk about psychosis during pregnancy and postpartum. Pregnancy does not protect against relapse. Psychiatric illness during pregnancy predict postpartum psychosis. It's very important. The risk of perinatal psychosis is 0.1 to 0.25% in the general population, but is about 50% in women with a history of bipolar disorder. That means if you have a patient with bipolar disorder and she is planning to get pregnancy in the near future, you have to tell her the importance of following up immediately once she discovered that she is pregnant. There is a 20-fold increase in the relative risk of psychosis during the month after childbirth. 20-fold increase in the relative risk of psychosis during the month after childbirth. The risk of recurrent postpartum psychosis is 50 to 90%, and I think all of us know that it's very important. If you have a patient with a previous history or past history of postpartum depression or psychosis, it is a must to follow up her carefully and even start some medications at the end of pregnancy that will not harm the fetus. The risks of not treating psychosis, and by the way, not to repeat this slide more and more again, the risk of not treating psychosis, not treating depression, not treating bipolar, it will lead to harm to the mother through poor self-care or judgment, lack of obstetric care, or impulsive acts. Number 2, harm to the fetus or neonate ranging from neglect to infanticide. Okay, so psychosis, depression, whatever, this is the risk of not treating psychosis or not taking care of mental illness during pregnancy. Treatment with antipsychotics. As I mentioned before, the recent research trying to elaborate the effect of all the new or atypical antipsychotic is not ethical to try a lot of drugs on pregnant women. That's why older or first generation, by experience and by finding that there is minimal or no harm for the fetus of using these first generation antipsychotic, are generally considered to have minimal risk of teratogenicity, supported by the wide use of them over several decades, as I told you before. There is most experience with chlorpromazine, but constipation and sedation can be a problem. Extremely low risk of an association between haloperidol and limb defect, sometimes neonatal dyskinesia or neonatal jaundice. And of course, it is very important to differentiate it from physiological jaundice that could happen in some of the neonates. Regarding second generation antipsychotic, the extent of placental passage, which means that the amount or the concentration or the level of the drug that can cross the placenta and reach to the fetus, is highest for olanzapine, followed by risperidone, followed by quetiapine. Olanzapine may be associated with low birth weight, macrosomia, and increased risk of gestational diabetes, which is a big problem in pregnant female. And of course, even without olanzapine, some of the females that prone to be diabetic develop gestational diabetes. However, which is very important, there is no clustering of congenital malformation, no known malformation specific for olanzapine. For example, like we'll talk later about lithium and Epstein anomaly of the heart. Okay, so no clustering of congenital malformations known, but there is an increased risk of gestational diabetes. And as we said before, if the patient receiving olanzapine before pregnancy and continue during pregnancy and gain weight, as I told you, she need a higher dose of folic acid to prevent against the risk of neural tube defect. Limited data suggests that neither risperidone nor quetiapine are major teratogens in humans. No published data relating to other second generation antipsychotics. Of course, because of this, you know that Maudsley guideline is published, I think, 2012, and we are waiting for the release of the newest one, I think, on the 22nd of this month, inshallah. Clozapine appears to present no increased risk of malformation, although, as olanzapine, gestational diabetes and neonatal seizures may be more likely to occur. There is a single case report of maternal overdose of clozapine resulting in fetal death. Of course, single case report, we can't depend on that. Clozapine, the NICE recommends to switch to other antipsychotic. But all of us know, of course, that we use clozapine in resistant cases, and if we switch to other atypical antipsychotic, the percentage or the possibility of relapse will increase. However, it will result in relapse. On the balance of evidence available, clozapine should usually be continued. NICE recommend avoiding, this is very important, and of course, easily to be expected, that avoid to use depot preparation, the long-acting injections, because of course, once you inject the drug, you cannot control its level and you can't stop it whenever you want, and anticholinergic drugs in pregnancy. Regarding depression during pregnancy and postpartum, approximately 10% of pregnant women develop a depressive illness and a further 16% a self-limiting depressive reaction. No need for the full criteria of major depressive disorder, but at least self-limiting depressive reaction. Much postpartum depression begins before birth of the fetus. New psychiatric episodes, 80% are mood disorder, primarily depression, occur in the first 3 months after delivery. What about treatment with antidepressants? The use of antidepressant during pregnancy is common. In Netherlands, 2% of women are prescribed antidepressants during the first trimester, which is not advisable, of course. In the US, 10% of women are prescribed antidepressants at some point during their pregnancy. The majority of prescriptions are for SSRIs. As usual, it is the safest during pregnancy. Patients who are receiving antidepressants and are at high risk of relapse are best maintained on antidepressant during and after pregnancy. Those who develop a moderate or severe depressive illness during pregnancy should be treated with antidepressant drugs. Tricyclic antidepressant, if you noticed that first generation antipsychotic, tricyclic antidepressants, all of them are of the old generation drugs. I think, as we said and noticed, because they are used for many decades without any obvious harm. Amitriptyline, triptizole, and imipramine, tofranil have for many years been agents of choice in pregnancy, but the anticholinergic side effects like constipation can be a problem of both. SSRIs appear not to be major teratogens. Data supporting the safety of fluoxetine, sertraline, or Zoloft appears to result in the least placental exposure, but the worst and better to be avoided is paroxetine or Seroxat, may be less safe than other SSRIs due to associated cardiac malformations, particularly after high dose, more than 25 milligram per day during first trimester. And we have to notice that it is more than 25 during first trimester. It may lead to cardiac malformations, but it is less safe than the other SSRIs. No increased risk of postpartum hemorrhage. You know, most of the SSRIs can lead to bleeding or increase bleeding tendency. No increased risk of postpartum hemorrhage, although they are associated with increased risk of bleeding. The neonate may experience discontinuation symptoms such as agitation and irritability, or even respiratory distress and convulsions, especially if the pregnant women use paroxetine or venlafaxine during her pregnancy, especially at the end of pregnancy. When taken in late pregnancy, they may increase the risk of persistent pulmonary hypertension of the newborn. So as we said in the earlier slides, the risk of psychotropic drugs is high during first trimester regarding malformations, and also high at the end of pregnancy regarding neonatal toxicity and the effect on the newborn, like pulmonary hypertension mentioned here. Bupropion or Wellbutrin exposure in utero has been associated with increased risk of ADHD in young children. So the use of bupropion may increase the risk of ADHD in the future for the fetus. MAO inhibitors, trazodone or tretico, mirtazapine or remeron should be avoided. As usual, ECT in Maudsley guideline have a big role in our mental illness. ECT, no evidence to suggest that it causes harm to either the mother or fetus during pregnancy. In resistant depression, NICE recommends that ECT is used before or instead of drug combinations. It's also written in the Maudsley guidelines that omega-3 fatty acids may be a treatment option. Regarding bipolar depression or bipolar patients, treatment with mood stabilizers in bipolar disorder during pregnancy is very important, stated clearly in Maudsley guidelines that no mood stabilizer is clearly safe. Women prescribed lithium should undergo high-resolution ultrasound and echocardiography of the fetus at 6 and 18 weeks gestation to screen for Epstein's cardiac anomaly. Valproate or carbamazepine, both teratogenic, should receive prophylactic folic acid, 5 mg per day, to reduce the incidence of neural tube defects. If carbamazepine is used during pregnancy, prophylactic vitamin K should be administered to the mother and neonate after delivery. Valproate, the most teratogenic, and the combination of mood stabilizers should be avoided. Lamotrigine or Lamictal may be associated with cleft palate. NICE recommend the use of mood stabilizing. This is very important, and I think I will mention it again in the conclusions, that NICE recommend the use of mood stabilizing antipsychotic better than the use of the known mood stabilizers or anticonvulsant mood stabilizers. In acute mania in pregnancy, use an antipsychotic. If ineffective, consider ECT. In bipolar depression during pregnancy, use CBT, cognitive behavioral therapy, for moderate depression, and an SSRI for more severe depression. In pregnant women with epilepsy, the same problem, anticonvulsants could be used as antiepileptics or as a mood stabilizer. So what about if the pregnant women had epilepsy? There is an increased risk of maternal complications such as severe morning sickness, eclampsia, vaginal bleeding, premature labor. Women should receive the lowest possible dose of a single anticonvulsant. What about anxiety disorders and insomnia? We will notice that it is better to avoid psychopharmacological drugs. Preferred treatments are CBT, cognitive behavioral therapy, for anxiety, and sleep hygiene for insomnia. Benzodiazepines are probably not teratogenic, but are best avoided in late pregnancy. Promethazine or Phenergan is widely used, but supporting safety data are scarce. Conclusion. Nortriptyline, amitriptyline, imipramine, and fluoxetine are the recommended antidepressant. And if you want to avoid use of some of antidepressants, it's better to avoid paroxetine, as stated clearly in Maudsley guideline. Number two, no clear evidence that any antipsychotic is a major teratogen. First generations are better than second generation. Consider using an antipsychotic as a mood stabilizer rather than an anticonvulsant drug. Non-drug measures are preferred in treating anxiety disorders and insomnia. Thank you.